it's kind of like there's a saying in dermatology, if it's wet, make it dry. If it's dry, make it wet. I like to say, if you're feeling terrible, try to use your head. And if you're caught up in your head, try to get in touch with your feelings. I am Dr. Carol Bernstein, a professor of psychiatry and neurology at the NYU School of Medicine.
Thank you for joining us on the 10th episode of the MD Edge Post-Call podcast. I'm your host, Nick Andrews. In this episode, we return to our conversation with Dr. Carol Bernstein of NYU on the differences between depression and burnout among physicians and how those two things could be incorporated. In the last episode, I opened up a little bit about my own experiences with ADHD. In this episode, we continue that conversation and dive into some other personal things as well. Here now, part 2 of my conversation with Dr. Carol Bernstein.
You know what the statistics show? I just got this from the ACGME today. How much they looked at a bunch of surgery and medical residents to look at the amount of time they're spending with patients now. What's the percent?
I'm going to say it's teens, 13.
12.
That's
12% of the time.
Wow. And
how bad is that? It's bad for patients. It's bad for clinicians. It's bad care.
It's, yeah.
And that's what burnout is. I mean, now, burnout, like any other negative experience, can lead to depression in some people without question. But I don't know that burnout itself is depression.
And that's where we get back to the English thing, where how words are used.
Right.
And
How do you
things
define
can be
it? Right.
clumped together that might not necessarily mean the same thing. I think having depression, clinical depression, is a medical issue, and that's a different thing. But if you're burnt out and a morbidity of that can become depression, we want to prevent that. We want to make being a doctor fun and exciting. And your struggle should be about, how do I treat this really complicated case? What's the ethics of, do I treat them? Is it better for palliative care? Those are the conversations.
How do we bring back meaning into medicine, connection to patients, and connection to each other? So the healthcare team, we need to care about each other. And if we care about each other, then we're going to care more about our patients without question.
Sure.
And patients don't want angry, irritated, pissed off doctors. They're not going to take good care of them, really.
Sure.
It's like, get out of here. I want to go home. I want to be with my family. Forget it. And it's challenging now because the whole work-life balance thing, or work-life integration, because we have these things, there's no separation. Now, if I'm feeling burnt out this week and I go on a vacation to Tahiti for 2 weeks, I'll probably feel pretty darn good in Tahiti. So that's why burnout's a funny concept. Whereas if I'm depressed, even a vacation in Tahiti isn't going to help.
Right. No, I see what you're saying for sure. And I guess that's the something that can be taken away from this, is that if burnout is leading to depression statistically, that would be an interesting question. That I think.
Well, I wouldn't be surprised if in some people it does, just like grief and loss can lead to depression in some people. But in and of themselves, grief and loss are not medical illnesses.
Not the same way.
And I don't think burnout is a medical illness either, as we define it. Can it lead there? Is it a continuum? I don't think so. Because the things that contribute to burnout are both, definitionally it's systemic, but we bring what leads to depression is what we have ourselves and what else is going on in our lives. So you have, your external, your home environment and personal environment, your work environment, and your biochemistry.
Right.
Your physiology.
That makes sense. I think physician burnout is not a topic that I was familiar with when I started my career, and now it's like, let's address this. There's a lot of people who want to talk about this. And it's where, honestly, if I want to pat myself on the back a little bit, my muggle metaphor gets a little bit deeper. There's a second level to it, which is that I feel as if high-level medical professionals, MDs, PhDs, elite, educated practitioners who deal with patients are, as they get further and further into the world, get further and further away from the pop culture zeitgeist, and it seems like it's isolated. And one example of this is how doctors are portrayed on TV in dramas, which is, for lack of a better term, bull.
Right, absolutely.
which is, to me, it's like, and the things that can do to your psyche, I'm not sure. Like, do I have to look like George Clooney and act like that? And do we save
Right,
every patient? It
right,
becomes a
right.
procedural. But the point of what I'm saying is that it's actually over here, and that this community is so isolated in their, magical world, that I don't know that the general population understands what it is actually happening. So when the doctor turns her back to you and enters all your stuff in the EHR, you think that the doctor's being rude. I have to do this.
Right. And I think that with the National Academy of Medicine's Action Collaborative, one of the challenges now, this has sort of been the perfect storm. The suicides have sort of been the tip of the iceberg, but the perfect storm has been what's happened to medicine in this country. We have a terrible healthcare system. Everybody knows it. We are way behind the rest of the developed world in how we take care of patients and our outcomes and in everything. I call it the medical industrial complex. I shouldn't do that, I suppose. But it's all about produce and money and status and prestige, and we're losing the meaning. I think this is happening in healthcare and it's happening in higher education, and that those industries, if you will, have always been about a higher calling. I don't want to say isolated and God complex,
Sure.
but it's been about altruism. And if we take away the meaning and the connection and the altruism, who's going to want to do this, really?
Right. Yeah.
And the patients are going to suffer. And we worry in the National Academy, as this happened, this perfect storm with everything that's going on in healthcare, trying to help the public understand that helping clinicians feel better is, in the end, going to help the patients get better.
Yeah, I use sports metaphors to explain every day I learn something new about the system, as it were, and I use sports metaphors because it looks like you commit your whole life to this, and it's harder, and as you go along, you're a little bitter. And what I've noticed is that the best teams in sports are the ones that recruit the best. They want the player to come to our big, sexy university.
Right,
It's beautiful.
that's
There's a
right.
barbershop downstairs. You can do whatever you want. In medicine, it seems to me that the recruiting it's sort of inevitable that you want to come to this place. We don't want you. And if you prioritize the talent and want it to be a happy environment, they want to be there, and it goes the other way.
Yes, and what I've said to people when they talk about how to assess things, I said, look at retention. Look at retention. If people are leaving in droves, you got to look at what's going on in your culture. And wouldn't patients want to be where doctors are happy?
Mm-hmm.
Wouldn't you? We have nursing satisfaction surveys. We have patient satisfaction surveys. There are no doctor satisfaction surveys. And I want to get away from, I know that there certainly also has been a shift in the status of physicians as patients know more and they want it to be a partnership, which is completely a great idea. And I don't think doctors should be on a pedestal. On the other hand, with all the talk about teams, if everybody's responsible, nobody's accountable.
Yeah.
So the buck has to stop someplace. And what has to happen is, I think the buck should stop with the doctor, but I think that everybody needs to be valued. The patient needs to be valued. The nurse needs to be valued. The social worker, all parts. Everybody has to have a purpose and a value, but we're not interchangeable pieces.
Yeah, that makes sense to me. Well, the team trainer didn't, throw a pass, but he got a Super Bowl ring, which is a true story. If you're a trainer on these teams, you get a ring.
Oh, interesting.
Right, but
Yeah.
their role is not to score
Exactly,
points.
exactly. That is a very nice analogy. I like that. And I also talk about one of the things I worry about with this generation is that because of burnout, there's this effort to protect the students, and they get protected and protected. When this is a tough calling. And when you go to the gym to build muscle. You need to be able to withstand some tough stuff.
Mm-hmm.
But that means not that you should avoid it, but that you need to be supported through it so that you can build the muscle.
Right, so
you
you
can't
like-
go lift 100 pounds right away.
Right,
you
it's
know?
the metaphor with the dude who carried the cow up the hill and the cow got older. It was a Greek myth. I'm not sure.
Oh,
if
you're talking about Sisyphus? The
Yes,
rock.
Sisyphus. Yes,
Sisyphus, the
Sisyphus.
rock. It wasn't a cow, it was
I thought
a
it
rock.
was, yes. All
Well,
right.
you came from the West, so you're allowed to say it's a
Yes,
cow.
the education system in Wyoming is
Right.
not what it could be. I think that the way that students look at residents, look at fellows, look at attendings, look at chairs of boards that should all look each other in the eye, in my opinion, in a perfect team system would be like, I went through this, you're going to be fine.
Exactly.
It's going to suck. I'm not
Exactly.
can't sugarcoat it. Like this is gonna suck, and
That is
I
correct.
don't feel bad for you.
That
You can do it.
That's correct. And that's not happening. That is what happens in the military. That is what happens in sports, right? Both of those, take those analogies. They say this is going to be tough. You're going to go out there. You're going to be in Afghanistan. This ain't going to be easy, but we will help you. You will get through it. It's going to be hard.
Right, where you go through the basic training. You hear these stories from World War II and Vietnam where people are awake for like 41 hours. Like, this is why they almost kill you at training. So that
Right,
you
right.
can,
So you
when you're
don't
there,
get
like,
dead.
Right.
Exactly.
I got
And,
it.
but the answer has been to
Sure.
try to keep, the answer has been to try to overly protect people, I think.
And I think that's representative of what's happening in pop culture as well. I was laid off at one point from cuts at a company, and like nothing teaches you a lesson like that. Like I will not have
Right,
skills next time.
right,
So,
right.
but if I'm protected by that, and there's 2 minute safety nets, at some point I don't bet on myself.
Well, that's true. And the other problem with burnout is if you don't have if you don't build up the muscles gradually, you rip them. So if these kids are protected totally, then they're going to get to be attendings and they're going to totally flip out.
Right. Oh yeah.
You see, that's what I'm saying, is that it has to be gradually scaffolding them, but you have to let them fly. It's like we have to let our kids fly. Like I have to let my daughter do her thing in Chicago.
Yeah, we'll get into
even
that.
though
I
I want to
can't wait.
I want to protect her forever, but
Yeah, no, and I that makes total sense to me, and I think that as you watch residents become, interns to chiefs to attendings, it's really interesting to me to see
that's
like
correct.
defend the system. Like, hey, I did it, and now I feel better, and I have all the
Yes,
confidence.
it is true. They get out, and the people now that are becoming most burned out as the students and the residents get more protected are the junior attendings.
I imagine.
And and I worry they're going to leave. And you know what? They're not going to have any institutional allegiances. They're going to say, "I'm done here. I'm going to greener pastures."
Well, that's the sports metaphor where you say, like, man, if this team isn't winning in New York, I'm signing with San Diego.
That's
I'm out.
correct. That is correct.
Right, and I think that there was in the 90s and 20s there was prestige for playing with the Yankees, but now they're like, I don't know, there's no
Who
taxes
needs it?
in
Exactly.
Colorado.
Exactly.
Pretty nice out there. They're
Exactly.
Nice to me.
And New York is pretty tough, so I think it's
I've
it's
heard
tough here.
Yeah, I
it's
live
tough
in
here.
I live in Little Brother, Philadelphia, which is
Where's
Diet
Little
New York.
Brother?
Yeah, Philadelphia, Diet New York. It's the same sort of. It's exact so much similar cultures like pizza and bread and all that, bagels.
I see, but where in Philly? I went to college there. And
Old City.
You mean
So
down?
I live in like the 2nd Street area.
Yeah, I know exactly where you live.
Yeah.
I know exactly where you are. Yeah, I lived. I met my husband when he was chair of psychiatry at Hahnemann, and we had a house on Pine and 20th. So
Oh, all right. I like.
and I went
Center
to
City.
college
Yeah.
at Bryn Mawr, so I know Philly.
Oh, Bryn Mawr. Yeah, that's at the west, right?
Yeah, that's the West. That's far away.
that's west.
That's
That's like
another story.
Manioc
That's
and-
another story.
Oh, Philly.
Yeah, Philly.
But I noticed this when I started diving into it about like how these big sexy institutions you work your whole life. Like I have been offered a position at Brigham and Women's or
Harvard,
MD Anderson
right,
or
right,
Harvard, yes,
right.
and you say like this is going to be great, and then not to call out those schools specifically,
Right,
but to say
right.
like in general, the more prestigious the institution, the more horrific the anecdotal stories I've been told.
Well, yeah.
Yeah, you don't have to get into that.
No, I don't. I think we better not get into.
Yeah, no specifics, but the point is that
It's true. It's true.
Yeah.
When you're at the top of the mountain, it can be pretty bad.
Well, and then it's like every other thing, and one of the great things that the internet has done, and that hipster culture, as I call myself a weekend hipster,
Yeah.
that hipster culture has done is people are willing to sacrifice either prestige or money in order for happiness and work satisfaction.
No question. And that is what's going to happen. And these big places, which are getting so caught up in the prestige and the Harvards and the Yales and all of that, they're going to lose out in the end because this generation is going to say, no, I want to go where people care about each other. That's what I want to do.
Right, the pursuit of it's
Right.
always interesting. I remember when I reported news back in Wyoming and in Mississippi, that every year or so, like Forbes or somebody would put out a list of the happiest countries, and
Yes,
metric-
Bhutan, right?
Yeah, the metric was always income versus taxes versus healthcare. And I thought these are just data points. What's the happiest country? This is not reportable. So when we've started to, as Thomas Jefferson put it, pursue happiness instead of pursuing outcomes, People are going to leave these things.
That is correct. And we are totally stuck on outcomes and metrics. And that, forgive me, is where I think the EHR inadvertently has, besides the general problems with it, the metric focus. Everybody's about metrics. It's like everything in the literature in medicine is about statistics. It's like it's statistically significant because of X. And I'm like, if you have a large enough N, you can prove just about anything. And if you flip a coin up in the air 100 times, half the times it's going to be heads and half tails. And so what?
Right.
You know, and I've become a little nihilistic about a lot of the literature, because in order to get your work into the literature, you have to show something that's statistically significant. And correlation is not causation. That's
Right.
not the way it works.
Right, and I think is one of the reasons I like to. I'm very romantic about the movement in oncology, both in pop culture and in medicine, with immunotherapy and genes
Yeah,
and stuff.
immunotherapy is.
Yeah, and the reason I like this is because it feels like, because I fantasize about what different periods of history would have been like. It feels like maybe Cape Canaveral in the 60s and 50s. We're like, we're all going to do this thing. We are going to end this thing. And it feels exciting. But what's coming out of that, the term I heard over and over and over and over again was individualized medicine.
Yeah, personalized medicine.
Correct. Like I'm treating
Right.
the cancer, I'm
Right.
treating the heart failure, I'm
Right.
all of this it's a three-dimensional metric of a human. And the literature might say statistically significant chance of this, but like this person in front of me, I think it's going to be
100%.
this way.
Well, and that's so that clinical sense of the patient is what you do. We need to look at populations. That's absolutely true. But what matters is what happens at the individual level. And that's where clinical experience, which is not metricized,
Yeah.
is so important. I mean, I remember to this day when I developed a stomach ache, and I thought it was my husband had a GI thing. It was a GI bug, and I was sort of like doubled over. And I called my internist, and I said, I think I have this GI, blah, blah, blah. And he listened to me on the phone. He said, go to the ER, you have appendicitis. I said, what are you talking about? I'm way too old to have appendicitis. I had appendicitis. He got that from talking to me for 10 minutes on the phone.
Yeah.
You can't, that's exceptional.
Right.
That's what we're losing in the metric game. We need to figure out how to harness metrics to help with clinical decision making, not to use them instead of clinical decision
Right,
making.
and that makes total sense to me. Like when I moved to because I college and moved, my parents moved, etc. When I moved here, I got a primary care setup. She is an NP, and I've been going to her now for 3 years. I'm like, at this point, you remember me. I remember
Exactly.
you. I'm done. If I can drive to you within an hour, you're the one until one of us
Well,
dies.
she also, because she sees you,
She'll be able to
knows
tell.
you,
Yeah.
she'll say, I'm worried.
Yeah. Well,
Or
like,
I'm not worried.
yeah, like everyone else in the world, like exercise is something I've been trying to
Right,
do this year,
right.
and I had not experienced the changes in like my physique that I wanted, but my blood pressure was down, and like my heart rate was up, my O2 stats were up, and she's like, yeah, these are noticeable
good
measures.
thing.
Like these are it's clearly been working. This is why I want a relationship with my PCP, or if you had cancer, you'd want a relationship with your oncologist, or if you felt like
Exactly.
you needed a psychiatrist, you want a
Exactly.
relationship with your psychiatrist.
And you can't have a substitute.
Hmm.
People don't want substitutes.
No.
I mean, my uncle at 98 had a new TAVR aortic valve replacement. There were a lot of good people on the team. He wanted the surgeon to talk. After it was done, he wanted to talk to the surgeon.
Sure. Yeah.
No substitute.
Yeah,
No
it,
substitute.
it really makes a difference if you're willing to put in the face time with the patient, and the patient wants to see you. And like I find honesty in medicine from physician to patient goes such a long way for the patient saying, like, man, if you did everything you can, and here I am on the 10th floor of Cornell or Weill Cornell, and the surgeon did like, all right, I'm in New York City, this is as good as it gets. So I believe that you did everything that you could do. And if
It's true, but the relationship is really important, and that's what we're losing. That's what matters. Everybody laughs about Marcus Welby, but Marcus Welby loved his patients, and his patients loved him. And we all want some of that. Yes, we want a team. Yes, we want it.
Yeah.
But and now, especially that people are living longer with chronic illnesses, whether it's depression or cancer or HIV or whatever.
Yeah.
Really important to have that relationship.
Yeah, so like if you as a practicing psychiatrist saw a patient and they looked like they lost about 10 pounds and they weren't trying, like, I'm going to sniff this out. But if you
Right.
hadn't been seeing them for 10 years,
That's
would it
correct.
quite be the same
That's
thing?
correct.
Yeah, that makes a lot of sense.
So
to me.
you see now why burnout has become such an issue.
Yes, and now that I've dived into it, because at the beginning of my medical career, as I stated, it was oncology,
Yeah.
and then I started wanting to do the podcast. I said do burnout, and I just looked into it, and it's a weird rabbit hole, because there's no when you deal with the medical system in the United States in the 21st century, there is no solution, and it's the only system I've ever seen ever that doesn't really actually benefit anyone the way they'd like it to,
That is
which
absolutely
is
true.
crazy. The
And I-
patients, the government, the pharmaceutical
The
company,
good
nobody gets what they
news-
want.
The good news is that now way more people are talking about single payer. I mean, it's not national health insurance, but it's single payer. We have to get this is never going to work as long as the insurance companies are in charge. It's just not going to
Well,
happen.
and I see.
Sorry, I'm saying that
I'm-
personally.
yeah.
It's completely crazy.
Well, yeah, and I my opinion wouldn't be wrong. I have no idea what I'm talking about. I'm doing my best, but I think that it's so many problems in America. In my opinion, are that like America's really big. There are four
Yes.
times than 300 million people. Of course, having all of these different insurance conglomerates is not going to work out, because if this person smoked for 50 years and this person was healthy, this person's in Colorado, that person's in Florida, it's going to be different.
That
and
is
and
correct.
what's the insurance company supposed to be like? We're trying to survive, because if we don't survive, 20,000 people are laid off. Nothing is working for anybody.
No,
they
that's
don't want the
completely
policies to
correct.
be this expensive. Nobody
That's-
wants this.
Yeah, but also the insurance companies are set up to make money. They're not set up to take care of
And
patients.
I
End of story.
right. And that's where you get into policy, et cetera. Like I have weird ethical dilemmas about prioritization, and not necessarily just in medicine, in everything, right? I don't like that people are so money hungry on Wall Street, but I also like that my school got a $50 million donation, and I enjoyed the library that they built, and I benefited from that. So it's just, at what point do you draw the line where somebody needs to step in and fix something?
Well, someone said there was a whole at one of the NAM meetings, the National Academy meetings, we had 30 people in a room, focus groups, different ages, pharmacists, nurses, doctors, talking about the ideal system, and one of the young doctors there, who's in training still, said to me, and it's just resonated with me ever since. What has to happen with these big systems is they should be making just enough money to do a good job. They shouldn't be in the business of racking up $20 gazillion extra. That you need to make money to have to be a going concern, but they really should be nonprofit.
Right.
But they're not, and there's a lot of waste in the system.
Well, and think about because I had dreams of being a reporter for the Wall Street Journal when I was in
Yeah.
college, and so I learned about the financial crisis. If they show this much growth from
Yeah.
gaming this system, that's great. But then the next year they got to beat that to attain the
correct.
growth. But the only way to do, hiking prices and different policy problems, and then you start jerry rig epics so that the certain procedures are not what they look like. And it's, man, if you had set your target a little lower, that growth would be sustainable.
Well, I mean, but you also look. I mean, everything is jerry rigged. I mean, I was listening to something somewhere maybe it was on the news, talking about the difference in cost for an infusion for a cancer drug versus a pill, and that the infusion, it was like on 60 Minutes or something. It was like the infusion, was going to cost the system thousands of dollars, and the drug was going to cost the system $2. Now, of course, the doctor's going to want to give the patient the best thing, but then the patient got charged with
The most passion I ever put into any piece of writing that I ever did was on financial toxicity.
Yeah, right.
That was really fascinating to me, because the FDA can't regulate the cost of a drug to be a comorbidity of tolerance and adherence. You can't ethically put people into a randomized trial where hey, you might go bankrupt. We need to see if it kills
Right.
you. But that's absolutely happening everywhere. We have to make these decisions. I want to take this drug, but if I take it every other day, I'll probably be all right, right?
It will cost less.
It will cost less. Right. But then
Well, we got to get control of pharma, and we have to get control of the insurance industry.
I don't mind them being motivated by money. I mind them being motivated by cheating. You know
Well,
what I mean?
cheating
If that
and
makes sense.
greed.
Yeah,
Too
cheating
much
and
greed.
greed. One thing I learned about the financial toxicity in the study was that in these immunotherapies, I specifically remember there's an arm of Keynote, I think it's Keynote 006 was the arm of the study, and they were testing different dosages of pembrolizumab for non-small cell lung cancer. And they found that pembrolizumab works, but they wanted to find, let's play with some dosages, and one of those was 10 milligrams per kilogram, and that cost $1 million a year. That is crazy. And then I talked to someone, I forget who makes it. I talked to someone there, and they said the margins on this drug, we would make money, but it's not what it sounds like in $1 million a year. It costs that much to make as well. but the margins on things that are, I just watched a documentary on medication for things like Wilson's and HIV. That's where the system is being gamed. And that the pharmaceutical companies are making money, but the insurance companies got it. Like, they don't know who's costing, so they got premiums are up. It's a Rubik's cube with like it's unfixable.
Right.
So you got to start
It's a
from the
mess.
top down. Yeah.
Right.
Which would burn me out.
Right.
I'm glad
All
I'm
of us. All of us.
So we'll get into like some personal stuff if you don't mind. You and I were speaking before we got here, and you have a daughter
Yes.
who is in Chicago.
Yes.
Who recognized that she's like, I'm not going to get burnt out on college. I'm going to walk dogs and babysit dogs.
Right.
And how's that going?
She seems to be doing well. She says, I am getting myself together, Mom. Takes a little while, but I'm getting myself together. And I will just share that, her friends in New York said, well, if you're going to work, why don't you stay at home and get a job? She said, because if I do that, my mother will do everything for me and I will never grow up. And guess what? She is completely right.
Yes, absolutely. Like, hey, dinner's at 7. Like, I'm 20 years old.
Right. No, much better. We need to have the lifeboats ready, but we need to let our kids grow, just like we're talking about the students and the residents in medicine.
Right. I think on the last podcast that we did with Dr. Norris, she said something really fascinating, that residents used to have like a midnight dinner when you were in training.
We did. I may have said that.
Yes.
We did.
And how was that?
It was fabulous.
It's something you look forward to.
Yes. And, if you did that now, think of how that would change the on-call experience. Everybody together. Big plate. It was a buffet. Everybody would just know at midnight you can go up and grab some food and see your friends.
You got 5 minutes of saying, like, how's this? But you wouldn't believe what I had today. Like, this is
right.
Yeah.
Exactly.
And I see that, in my opinion, for many literary reasons, but also for what it's done, Scrubs is a really fascinating show, and that seems to
I
me
haven't
like
watched it. Yeah.
it is. It's the most accurate. From what I heard, the word I keep hearing from attendings and residents who watch it is triggered. It's so accurate that
it triggers things.
It triggers them. Yeah. But and I always say that it uses humor to mask the immense sadness in the medical system.
That is correct. Well, The House of God came out when I was an intern, and
the episode 3 and 4 of the Post Call podcast was an interview with Samuel Shem.
Well, he's here. He's actually talking tomorrow, next week.
Yeah, I still have to thank him for being on that. His episode dropped about a month ago.
Yeah, no, it may be next week. I don't think it's today, but
he's
talking about House of God today.
Yes, I hypothesize that we'll look back in 50 years as American literature and say that was a really big moment. That book really sort of was the original whistle on the system. And he'll take credit. You can't imagine what it was like to read that book when you were an intern, when it was happening to you. And I also started in medicine and switched to psychiatry. But I'm like, oh my God. Yeah, so I'm actually dating a resident, and we don't really share that in the air. We'll cut that out. But she told me when we met, we might leave it in, I don't know, like, nobody understands. Here, read this book. And I read the book, I'm like, this is
There's
interesting.
another book that was written by Martha Lear called Heart Sounds that you might want to.
That's a good one.
I don't know if you
I'll
can even get it. She was married to a physician. It's not the training piece, but it's another. It was a book that came out around the same time.
Yeah, he was really fascinating. Because he teaches about, like, not necessarily medicine, but like something on like the precipice of medicine, right? At the School of Medicine here.
Yeah, he teaches. He's a special professor,
like a lecturer.
Yeah, he comes, and that's what he's doing. I think it's next week.
Yeah,
he's doing a whole thing on the current House of God, and I think that people who were with him, who represent the characters in the book, are going to be there. So I've thought that I should go. I signed up to go. We'll see if I go. I think it's next week.
Well, Scrubs is based on the House of God loosely.
I see.
Yeah,
I see.
and they did a bunch of things for TV sitcoms.
Well, humor helps with the tough stuff.
The gallows humor is a big deal.
No, and it really helps. And because it's a way we get through stress. And so those are ways to build resilience, which we have to do.
Yeah.
You have to build resilience. It's important. Dennis Charney is the dean at Sinai, and he's worked in psychiatry and resilience his whole career. And I was at a symposium at the APA in May, and he put up a slide that talked about facing your fears as being really important in building resilience. And it's like emblazoned in my head, even at this late stage of my career.
Yeah, having those things to look back on are, I'm sure, really impactful. Now, before we wrap up, I wanted to ask, so for someone who may be listening to this at any point, because it lives on the internet, who's feeling burnt out, who is worried that it's going to turn into something clinical. Do you have any advice, or what would you say to them to get through the moment and then moving forward?
Talk to the people that you care about. Talk about what's going on. Reach out if you can. That's the first step of all of it. You'd be surprised about how many people will want to help you, and they can help you get to resources. And also, I think, to understand that we all have these feelings and they come and go. And to think, maybe if you can, to think ahead of time about when you're down and out, what are the things that help you get through the tough time?
Sure. No.
What are the things that, so if you think about that ahead of time, when you're feeling bad, then maybe you can
having your tool.
like I find when I'm feeling particularly terrible, listening to music really helps a lot.
I have a list of like 5 or 6 go-to videos on YouTube. I thought that one of them might actually help physicians with burnout. Whenever I'm having a bad day, I watch patients getting their cochlear implants turned on.
Yeah.
Because that is this is, if I were a doctor, I feel like that's why you would do it. This is a problem, you fix the problem.
So to be prepared helps, but really to reach out to the people that care about you. That's the most important thing to do first.
If your knee hurts, you go to the knee doctor.
Well, and if your heart hurts, go to the heart doctor.
Yeah, absolutely.
If you're feeling really down and blue. And I think also, it's kind of like there's a saying in dermatology, if it's wet, make it dry. If it's dry, make it wet. I like to say, if you're feeling terrible, try to use your head. And if you're caught up in your head, try to get in touch with your feelings.
Oh, that's interesting.
It's a little bit of a loop. Right. So our heads can sometimes help us. Writing things down can help. Talking it out. Thinking ahead about the things that make you feel better.
And that concludes this edition of the MD Edge Post Call podcast. I'd like to thank you for hanging out with me once again this week, and I'd like to thank Dr. Carol Bernstein for agreeing to sit down with me to discuss this very important topic. Dr. Bernstein, of course, was featured on an earlier episode of the MD Edge Psychcast. You can find the MD Edge Psychcast and Post Call wherever podcasts are found. For Dr. Bernstein and all of us here at MD Edge, I'm Nick Andrews, and you're listening to the Post Call podcast.